right, so we'll get started. Hello, everyone. Welcome to the Journal Club for Representation in Rehab. We have two amazing students here with us that will be sharing, as well as a wonderful attending. So excited to hear from them. Thank you for joining us today. This will be recorded and posted on our YouTube channel, so just to let you know. And so today we are talking everything sports med. Our first speaker is Josephine Nawakno, and she is a third year at the University of Missouri, Kansas City. And we also have Karam Hamada, who is a third year at the University of Kansas School of Medicine in Wichita. And our attending today with us is Dr. Cameron Fausett. He completed his residency at the Shirley Ryan Ability Lab and graduated from the Stanford Non-Operative Sports Medicine Fellowship last year, and now he's a attending. So we can go ahead and get started. Whoever wants to go first, you can share your screen. And Dr. Cameron, whenever you have input, feel free to comment. Yeah.
Fantastic. Great.
So whoever would like to go first, you can go ahead and share your screen.
Do you have a preference, Karam? I don't mind either way.
Yeah, I don't mind. I can go. It's okay.
Okay.
Awesome. So yeah, hello everyone. My name is Karam Hamada. I'm a third year, as mentioned. Here, let me share my screen real quick. And thanks to everyone for tuning in, and nice to meet you face to face, Dr. Fausett. Yeah.
Likewise.
Yeah. Okay. All right, when it's presenting now, does it present like the full screen, or does it show the thing with like the two different screens?
It does show the two different screens, or the presenter mode, I believe.
What about now?
Now you're good. Now it doesn't.
Okay. Awesome. So hello everyone. I'm going to talk today kind of about the effect of this cool warm-up program called the FIFA 11 warm-up program, 11 plus. And we're going to talk kind of about its impact on soccer injury prevention. And there was a recent study that was done that kind of helped kind of give us some more clarity on this. So as mentioned before, my name is Karam Hamada. I'm a third year at the University of Kansas School of Medicine in Wichita. So just for an agenda, kind of we're going to hit background, population, methods, results discussion, all the fun stuff. A little more about myself. I was born and raised here in Kansas. Grew up in an area that did not have any PM&R doctors, so I didn't actually even know what this field was until I came to medical school. But then I kind of fell in love with it for many reasons. My love of MSK, love of neuro, but also just I love being able to like help people kind of pursue their passions. I'm someone who loves to eat all kinds of different cultures of food, loves to meet all kinds of different people, and loves to travel. So here's just some pictures of my escapades. But yeah, so kind of going on into the background. The reason I think this is important is because when you look at soccer players at all levels, there's a high incidence of injury. As like they said, between 1.2 to 18.8 per 1,000 hours played. The most common types of injuries that we see are sprains, strains, contusions. And the reason that this is important to address, especially in the population that I'll talk about in a second, is because when you get injured and let's say you're a professional player, semi-professional player, it's not only like a loss of income, but you have difficulty in obtaining alternative employment possibilities, especially when you're in these under-resourced regions. So like it can really impact your quality of life and impact like the things you can do in your life. So there's a lot of previous studies before the FIFA 11 plus warm-up program that have shown that if we do this limited intervention, like this one exercise or this one intervention, we can help prevent specific injuries like they saw with the Nordic eccentric hamstring exercises, or some specific balance and proprioceptive exercises, or orthotic pieces for ankle injuries. But when we look at soccer injuries, the hypothesis is that a multi-modal intervention is necessary that incorporates core strength, balance, coordination, and plyometrics. Because it's a really complex sport, injuries are usually as like a lot of different factors are playing a role. So what is the FIFA 11 plus injury prevention program? So it was kind of developed by FIFA itself to kind of reduce perceived intrinsic risk factors. They have 15 overall base exercises that are performed in sequence during a warm-up. So it's like a standalone program that you perform before training or before a match. And it kind of has 8 minutes of running exercises, about 10 minutes strength, plyometrics, and balance, and about 2 minutes of running exercises to finish it out. You kind of work together as a team. You can also do individually, but it involves kind of slow running and dynamic stretching. There's 6 different sets of exercises that target the trunk and legs with 3 different levels of progression. And the running drills also increase speed with different complexity of movements. So what had been done before this specific study I'm about to talk about is they saw that the FIFA 11 plus program is shown to increase general lower limb strength as measured by improvements in counter movement and squat jumps, also increase the peak torque of concentric and eccentric hamstring strength, and neuromuscular control, which we're going to talk about a little later, would correct alignment of hip, knee, and ankle joints during dynamic movement. There were 4 randomized controlled trials done on this before this study. 3 of them were on males, 2 of them were on youth, and 1 was on veteran players. The study in Nigeria on 20 youth teams kind of saw a significant reduction in incidence of all injuries, but it was really limited on like what types of injury and how severe the injuries were. And they did a large study on USA college male players and then demonstrated kind of a 46% reduction of injuries and time lost injuries. But the thing that's important to know with USA players in the college is that this has much less exposure. They have fewer matches, fewer practice than your average professional team, and obviously a shorter season, 5 months versus 8 to 10 months. And we'll talk a little more about that as well. So this specific study was performed on the Rwandan Second Division Youth Soccer League. There's 24 teams, 630 players, and about 26 people per team. The reason that this study was a good choice is because it's an amateur league with no competitive experience and had previously no exposure to the FIFA 11 plus program, which potentially could predispose them to more injuries. So it allowed us kind of to have like a better look at differences between a control and intervention group. So the aim was to determine the impact of a FIFA 11 plus, not only on injury incidence, but also on location and on the severity of injuries. So the previous studies in this region showed that 70% of Rwandan soccer players had an injury within a year. The mean age of players in this study were about 20 years old with a mean BMI of 22.6, and they were all pretty amateur with only 3 years of kind of playing experience. The max of anyone in the study was 6 years of professional playing experience. So going into criteria, they sampled the teams rather than sampling the individual players because the implementation was carried out at the team level. And it kind of calculated the sample size of 217 for the control and 217 for the intervention, and they did meet these calculated sizes that they were going for. Inclusion was just people with contracts and licenses, and they only had like 3 or 4 people that were excluded, and it was due because they had to move away for relocation for family or education, stuff like that. So these are the instruments that they use in the study. They did a self-designed demographic form, a standardized FIFA training form that it was administered every 2 weeks for both the control and the intervention to kind of see how they're going with their training and how often are they keeping up with it. And then at every match, the referees would fill out an exposure report, kind of looking at like time played, injuries that were conducted, or injuries that took place during the match. And that's also right here, the injury report every 2 weeks. This was conducted from training and also from the matches. This injury report is the same exact one they used during like the FIFA World Cup and the Olympics and stuff like that. So for the control group, they took all the coaches in this control group and they took them to a 1-day training where they taught them about like basically what is the occurrence of injuries in this population, basic first aid, emergency procedures, like what are like the phases of rehab and recovery that you would implement. And they just told him, we want you to continue whatever you're doing prior, like your normal warm-up regimen, normal practice. And they made sure that they never had any familiarity with this FIFA 11 plus warm-up program. The intervention, however, it was a multiple day kind of instructional meeting where they focus on prevention concepts. They took all the coaches, all the players, and all the medical personnel, and they talked about prevention concepts, development, and use of this FIFA 11 plus warm-up program. They gave them PowerPoints, videos, exercise demonstrations. They would like do role playing back and forth with the coaches, and their stipulation they let them go home with is that you have to do this warm up at least 3 times a week. And then in terms of follow up, as I mentioned before, the instructor and the PI would visit with the intervention group coaches about once a week during the first month of the season, and then they would follow it up with monthly visits. And the medical personnel recording the injuries and the research assistants were all blinded to this in a way to try to keep it unbiased. So this is what they did for statistics. They weighted independent t-test. The primary outcome with respect to efficacy of this warm-up program was the comparison of the incidence of overall training and match injuries per 1,000 hours. And we're looking at a 95% confidence interval. Something important to note is they did not find any statistically significant differences between the demographics of both the intervention and the control. Compliance was also measured. They wanted to do it as a percentage of how many sessions you do with our FIFA 11 plus specific divided by the total training and match sessions. The intervention teams had moderate to high compliance with this program in implementation 75% of the time. So I just wanted to let you know that ahead of time. And there were no difference in injury incidences depending on how much you complied, whether it was moderate or high, but we'll talk about that again. So no player was injured before the season started. That was something good to know. Intervention group had about 65,000 hours of total exposure to practice and matches, etc. But the control group only had 63,000. The reason for that is because the two teams that were in the intervention reached the championship, so that's why they had more hours of practice. And there was statistically significant greater total overall and training exposure hours in the intervention group. But that was also because of the reason I just mentioned. So here it is, kind of just going straight into the results. I tried to put a red box around everything that was statistically significant. But as you can see, if you look at the intervention and the control, for overall injury incidence, there is a statistically significant difference of 2.6 versus 4 in the intervention versus the control. So there was a reduction in the overall incidence of injuries, and that is a p-value of 0.001. Also important to note, same p-value for the match incidence of injuries was 24.2 to 38.6. Now, if we're going on to the risk of injuries and the odds ratios, the overall injuries risk was reduced in the intervention group, as shown here by the odds ratio 0.65, and also in the match 0.71. And the location of injuries was shown to be significantly reduced in the intervention group with 0.72 odds ratio, and 0.52 specifically for ankles was shown to be. So that was the biggest difference was seen specifically in ankle injuries. Mechanism of injury was also statistically significant, as seen by a reduction in both contact and non-contact injuries, as seen here with the reduced odds ratio of 0.56 and 0.46. And looking at the etiology of injuries, traumatic injuries were shown to be statistically significantly reduced. So now, again, going back at that severity, they looked at severity basically on how many days did you have to miss. And if you look at moderate, it was 8 to 28 days, severe greater than 28 days. And there was a statistically significant reduction in both moderate and severe injuries with 0.45 rate ratio, 0.29 rate ratio. So the players in the intervention group had lost 40% less days due to injuries. The median was 6, and the range was ranging anywhere from 1 to 84 days, but that's something important to note. And the frequency of players that sustained a similar single injury was similar, as there was 109 people in the intervention group compared to 98 in the control group. But the control group had more than twice the number of multiple injuries per player over the whole season. And also something important to note, there was not a single injury or adverse side effect that was noted during the FIFA 11 warm-up, whether it be during training or during the match. So kind of going into my discussion, you can see that the study showed that if you introduce this warm-up program and there's at least moderate to high compliance, which they defined as greater than 60%, you can it decreased the overall incidence of injuries by 11% compared to the control group. The intervention was also significantly decreased overall injury risk by 35%. And as I mentioned before, the intervention group had lower severity of injuries and fewer days lost compared to the control, and significantly reduced incidence of lower extremity, 28%, and ankle injuries, 48% compared to the control. So going into the strengths and weaknesses of the study, I thought the study was really good as it had a good sample size. They collected data over the whole season. There was a high level of compliance there wasn't a single team that was less than 60% compliance in the intervention group. And there was really good internal validity as shown as this demographics were pretty much the same among both groups. And there was longer training that took place in the intervention group compared to previous studies. As I told you, it was like a 3-day event. But in the past, they would only be training on it. They would only be learning about the FIFA 11 program for about an hour or two. The differences, however, were the weaknesses were that there were differences between the training times, due obviously to team progression, but also it's kind of reliant on coach motivation and an inconsistency between what is the control really for us in this study, because every coach could have their own different program, their own different warm-up, and they didn't really assess what was the coach's normal warm-up regimen in the control group. It was also hard to quantify kind of what counts as an injury. Some bias may be here as all the injuries were self-reported on the standardized form. So that was reliant on the staff to kind of fill out the forms. And also it was a team-based focus rather than an individual focus. But I don't think that team-based focus is as big a deal because the intervention, again, as mentioned before, was carried at the team level. So kind of going into the neuromuscular effects, studies before this showed how if you implement the FIFA 11 program multiple times a week, you have improved general physical fitness and improved neuromuscular control in these kind of population with youth and amateur players. Other studies found that there's an increase in abdominal, hip extensor, adductor, neuromuscular control, which may help with force distribution and proximal control. So this study's hypothesis or theory was that the improvements that are prevalent in these areas may have prepared players to withstand contacts that would have otherwise resulted in injuries. And this was shown because the study had decreased contact injuries in intervention. So that was their explanation for why we may have had decreased contact injuries. But contact injuries are very often multifactorial, and this study did not record the types and mechanisms of the contact injuries, which is obviously very hard to do in the first place. So the reason I think the study is helpful for us to I wanted to share with all of you is because match injury incidences are always consistently higher than those that are sustained in training. So if you can find any way to reduce the amount of injuries that take place in matches, that's always something you should take a look at. Also, this is a low-cost intervention. All you really have to do is learn the program and then kind of standardize it and spread it to either just use the league that you're working with, team you're working with. I think it's really important that they did this in this Rwandan league, an under-resourced community, because historically, if you look at the United States, soccer is something that it's getting better now, but it had been kind of limited for people of middle class or above. It was not the most affordable sport for people growing up in the United States, but it's gotten better now. But that's different compared to other countries such as Brazil or France, where everyone's playing soccer. So if we can find a way to put this in under-resourced communities in a low-cost intervention, then I feel like we can help implement this in all different demographic groups across the United States. Also, there's a possibility, some studies kind of complained afterwards that maybe we should look at a different way to deliver it, or can we incorporate it into the session rather than a standalone warm-up? So that is something we can possibly explore. Is there a different way to deliver the warm-up regimen? Other new studies kind of showed that it's effective for soccer players of different ages, gender, and all levels. There's a 2023 study that showed improvement in proprioception and kinematics among female and male adolescents. And a 2022 study showed improved jumping performance without compromising speed in female futsal athletes. So the reason I brought these up is because I was showing that something that within physiatry, sometimes you find yourself working with this adolescent population when it comes to sports medicine. And also I wanted to show that it's also shown to be effective in the female population because this was limited to the male population. So here are my sources. You can kind of look at it later, and that's kind of what I have. Thanks everyone for tuning in. Do you have any other questions at this time?
Yes, thank you so much, Karam. If anyone has any questions, also Dr. Fausett, if you have anything to add, that'd be great to hear from you as well.
Yeah, just first, any questions from anybody, or anybody have any specific thoughts on the study, whether they thought it was a good study, bad study? And that's okay, because I've got thoughts. So
I have a question.
Oh, sorry, go ahead.
I was trying to raise my hand, but I couldn't figure out how to do it. Thanks so much for the presentation. It was really good. And I think the study I agree with you. I think it's a great study. I was just wondering, did they comment at all on like any qualitative comments from the teams or the coaches on how they thought about the program, if they liked it, or just kind of their perspective?
So this specific study did not, but the other study I was trying to reference at the end, there was a New Zealand study that looked at all the football and futsal athletes in that area, and they complimented on it, and they were basically saying, like, yes, we see the benefit in the study, but we don't like that it's separate from the study. Like, we don't like that the warm-up program is separate from our training. We wish it could just be incorporated, and that would be just more seamless. They also wanted if you look at the warm-up regimen, for example, it's kind of general. They said it would be better if we could have exercises that are more soccer specific. But in the specific population, they did not have any qualitative feedback.
Yeah, that's helpful. Thank you.
Yeah.
I just wanted to ask because I don't have a background in sports, so this was really interesting for me. But I noticed when you brought up the FIFA 11 graphic, it had different sections to it. So my original assumption was that, oh, like athletes would, would have a warm up for sure before. And so what part of the I guess FIFA 11 would you think made such a significant difference? Because there's different exercises that I couldn't look at it too well, but what part do you think, contributed the most to why there was a significant difference? Because in my, like, not having a background in sports, I'm like, oh, I thought everyone, did this or that. So during their warm-ups.
Yeah, I mean, that's definitely a good question. I'm not able to give you a great answer on that. I do know that the combination is kind of what they were looking at, because usually when people warm up, they're only hitting like one of these things is what they were telling us in the background section of the study. But they said just being able to hit all of these categories, such as the strength, the plyometrics, the balance, and the fitness that are running, hit them all for a little bit is what they were looking at as their possible reason for why it's effective. Also, something important to note is the population that was chosen for this study, being in an under-resourced community, did not they did not have great warm-up regimens, is what the coaches were telling them. So they thought that a possible bias of the study was that those in the intervention group had a organized warm-up regimen, and they thought those in the control group may have not had an organized regimen. So that was something they were talking about.
Great, thank you.
So I'll jump in here with a couple of thoughts. First of all, great job with that. I thought the article was very nicely summarized and analyzed. And I think why I wanted you to pick this one and why I was excited to discuss it is because there's this concept of exercise as medicine that's been a big push by ACSM, which is one of the big organizations in our field. And to me, the power of this study is that they, I think if we go back to that one slide where it has all the exercises, I think this whole thing is supposed to take about 20 minutes when you do all these exercises. And they did this 20-minute warm up 3.5 times a week, call it 3 times a week. They didn't have any injuries or any issues with it. And it doesn't require any specific equipment. And they got a nice response in terms of injury prevention. So I thought that was a really kind of powerful thing, is that this is something that, you know, hey, maybe it's not perfect and maybe there's a better way to deliver it, but it's a fairly easy and low risk thing to roll out. As you very well stated, that this can be just rolled out, and this has been proven to work. And I think it actually is fairly applicable to some of our younger athlete populations, our youth sports, maybe club sports. Probably by the time athletes are getting to like the college level and certainly the professional level, a lot of this has probably already been incorporated into their warm-up routines, if I had to guess. Certainly by no means a high-level athlete or coach myself. But certainly at the youth sports level, having a sort of systematic warm up that targets a bunch of these different things, the proprioception, the balance, the strengthening, I think that's really powerful. And the other thing is I just love injury prevention. I think it's a really fascinating thing to think about, is what we can do to prevent. So much of medicine is reactive to something when something has already gone wrong. So if we can do something to prevent, that's obviously, in my mind, even more powerful than treating an injury appropriately. But injury prevention is notoriously challenging to study because you're trying to measure a negative. You're trying to measure something that doesn't happen, if that makes sense. But yeah, I thought that was a great article. Any other questions about that, or anything that I just said didn't make sense or needs to be further discussed?
No, thank you so much for your comments. I completely agree, and I'm happy that this is the study we ended up picking and everything, because I think it's something that if we could implement across the country or even just like in our local communities, it could definitely make an impact. Yeah.
Yeah, you know, like I said, I'm sure the pros are doing this and more, but at the club level, I mean, maybe even at like the high school and junior college level, I wonder what their warm up really is. There was one question I had. It didn't seem to impact overuse injuries, but it might have just been too small of a number of injuries to show a difference. So I wonder if that would be, I just kind of thought that was interesting. I mean, it's great that it prevented traumatic stuff, and specifically foot and ankle, which is far and away the most common soccer injury. So if you're going to work on trying to prevent anything, that would be the one you would pick. So, but I thought it was interesting that it didn't seem to help overuse injuries. I am a little bit concerned about like how it relied on the trainers to like record what was an injury and the severity of it and this, that, and the other, but they were blinded. Am I correct in that?
Yes.
Yeah. Okay. So I don't know. And how else are you supposed to roll it out? I mean, there's kind of no choice. Like that someone's got to record this stuff, and the players aren't going to give you any reliable information because they're just going to try and tell you that they're fine to get back on the field. So, in my experience, great job with that.
Thank you.
I just had a quick comment. Sorry. Also, like, really great job on this. And like, I was honestly not really aware of this program. And like, as someone who's played a couple sports before, I'd really be curious to know like how it would or will get implemented as far as like on the more local level of sports in the future. And I think it'd be something great, like that a lot of like athletes would benefit from. I guess another question that I was kind of wondering is how, or this may be a question for you as well, Dr. Fausett, but I guess like how can places or like I guess go about, or how can we or like people just in general, I guess like how will we be able to like increase awareness as far as like injury prevention and like getting programs and things like this implemented in like high schools or like college athletes? Like I don't know, because not everyone reads literature and is aware of things like this. So I don't know, just curious.
Yeah, that's a great question. How to get buy-in. I think the thing that leaps to my mind is when you would be covering a team. So you're the team physician, or maybe you're doing mass physicals for youth sports participation. You know, getting some face time with coaches or athletic trainers if a team is lucky enough to have a resource like an athletic trainer, and try to get their buy-in, see if they're aware of it, and see if you can kind of bring them up to speed on what is possible. And how I would do it is, you know, coaches want their players available and to play. And so if you could frame it along the lines of, you know, what's the best way to keep our team healthy and competitive and to keep people available, that's certainly how I would approach it. So but yeah, I think it's probably going to be an equal thing of like an organization like FIFA to kind of spread knowledge through like their organizations and their community efforts, but then also grassroots through people like us. I saw something come up in the chat, but I am on my phone, so I cannot figure out how to access that. Can somebody else read it?
Hey, it's Stacy. I can say it out loud. I was just thinking that like the applications of this can go beyond just sports. And I'm thinking of people and patients that I've seen who have had injuries, who are like roofers, who, you know, have catastrophic injuries, and then just like up on ladders all the time, to just like construction workers who have like more overuse injuries and stuff like that. I don't know. I've never thought to ask them, like, do you have a warm-up routine prior to your work? So I feel like this could potentially be could apply.
Yeah, I think that this could help. I think this could help a lot of different people, whether that's, you know, competitive athletes, recreational athletes, or yeah, people who just work a physically demanding job. You know, it's been a learning experience for me so far. The 6 or 7 months that I've been up in South San Francisco, which is decidedly a more blue collar working class, and just how physically demanding people's jobs are, and how it takes a toll on people's body, especially if you do that job for 20, 30, 40 years. So, but yeah, great idea, Stacey.
Well, thank you so much. Anyone have any other questions or comments? If not, we can transition to Josephine's article. Josephine, you can just share your screen. Take it away.
All right. Thank you, Bethany. And I will go ahead and share my screen. Okay. Alrighty. Well, my name is Josephine Wonkwo. I'm a current fifth year BA MD student at the University of Missouri Kansas City School of Medicine, originally from the great state of Oklahoma, specifically Oklahoma City. And I'm really happy to be here with you all today, talking about this article that I decided to pick. And we'll be talking about the influence of race, sex, and social disadvantage on self-reported health in patients presenting with chronic musculoskeletal pain. And then these are the authors of the article as well. Okay, so just a little bit of kind of some background. So it's pretty well known that health outcomes can be pretty heavily influenced by socio-demographic factors. Specific demographics like identifying as Black, being amongst the female sex, being more economically disadvantaged, have been cited to be associated with less access to care, rehospitalization, and worsened symptoms. There was a study done by 2 researchers specifically that kind of looked at these effects of like sociodemographic variables and their relation to chronic pain specifically. There was a study that I found as well that was done in 2017 as far as looking at racial bias when it comes to Division I athletes. This study showed that sports medical staff perceive Black athletes to have less pain compared to white athletes, and I think this is pretty significant when you think about when we think about how we all take into account our implicit biases when it comes to just like training, or even as students when it comes to caring for patients in the future. And another important thing to examine as far as this study, greater than 20% of our population is living with chronic pain from like various injuries, and so the way it tends to disproportionately affect certain populations is also important to consider. So the purpose of this study was to look at the association between race, sex, and disadvantaged status in self-reported physical and behavioral health in patients with chronic musculoskeletal pain. And the hypothesis of this study was that Black race, female sex, and social disadvantage would independently correlate with the worsened self-reported physical and behavioral health. So the design of this study was a cross-sectional study. It occurred in one academic hospital in St. Louis, Missouri. They did the analysis between 2019 and 2020. And so to be included in this study, you had to be an adult. You had to have visited a sports medicine non-operative physiatrist for some sort of non-operative management of a MSK disorder. They also required that you be following chronically or following with them over time for a chronic condition. And so there was a specific period of time. You had to have seen the physiatrist between January 2000 to December 2011, and then also had come back for follow-up between June 2015 and November 2017. So following for about a minimum of 4 years. And then you were excluded if you were considered to be like a pediatrics patient, or if your pain resolved and didn't require any further follow-up. So as far as data collected, so it looked at sociodemographic variables such as self-reported race, biological sex, and disadvantage status, which was measured using the area deprivation index, in which I'll talk a little bit more about on the next slide. They also took into account some other patient-reported data like age and whether or not they used opioid therapy for their pain, as well as their health insurance. The primary comparison measure was the effect size of the 3 main variables mentioned above on patients' self-reported physical and behavioral health, and that was measured by PROMIS, which I will also talk about on the next slide. Patients would complete this PROMIS measure prior to being seen by their physiatrist at their clinic appointment. Physical health was measured using the PROMIS physical function format, and then behavioral health was measured using PROMIS anxiety and depression domains. And then of note, as far as like scoring, so higher scores were correlated with more of that specific domain. So if you scored maybe a 60 as far as physical function, then that means you had maybe like greater, higher physical function, whereas if you scored a 60 with the anxiety and depression domain, that maybe meant that you had higher levels of anxiety and depression. And then other things, the minimal meaningful effect size on the PROMIS scores were estimated based on already published minimal clinically important differences, or an MCID, in patients who have been conservatively managed with musculoskeletal pain. And so I've listed the amount of points for each category here for physical function, pain, anxiety, and depression. Alrighty, so PROMIS stands for Patient Reported Outcomes Measurement Information System. And so it's kind of just like what its name suggests. It's a measure that the patients fill out and ask you a various amount of questions, kind of assessing your function, assessing kind of how you're doing. It gives the opportunity for the patient themselves to kind of complete and give a rating of like how they feel like they're doing as far as their progress Here on the right hand side, I have just a screenshot of kind of an example of some of the physical function questions they may ask. The nice thing about Promise is it's available in like paper and electronic formats, and then you can also kind of tailor it to specific conditions or injuries that you may have as well. And then the Area Deprivation Index, it's a measure that was created by the Health Resource and Service Administration, and it was validated by a research team at University of Wisconsin. It kind of helps to just provide like a ranking score or decile to rank how disadvantaged an area or a neighborhood is as far as their socioeconomic status. And so it takes into account multiple factors like your employment history, your education, your income, housing, things like that. And so this study was done in St. Louis, Missouri. And so here on the bottom right-hand side, I kind of have just like a screenshot of kind of how it looks. I'm not sure if you can see, but here in the blue color is more considered to be like a least disadvantaged area as far as, and then the red is more disadvantaged. And so you put in a 9-digit zip code and it kind of gives you like a decile ranking from 1 to about 100, with 100 being the most disadvantaged like area or neighborhood. So a couple statistics. So each promise measure was modeled using multiple linear regression. The independent variables included were patients' self-reported race, and that was collected as white, black, or other. Self-reported biological sex was reported, and then social disadvantage using like the ADI quartile was also reported. And then kind of like I mentioned before, they also took into account like whether or not a patient used chronic opioids, and then also the patient's age. And then they did a couple like kind of sub-analysis things using Pearson chi-square tests to compare race and sex breakdown between each of the ADI quartiles. Okay, and so from some general results, so almost 1,200 patients met the criteria. A majority of the patients who met this criteria were identified as far as their race were considered to be white, and then a female sex. Social disadvantage was found to be associated with a clinically meaningful worse self-reported physical and behavioral promise scores. Black race was associated with greater anxiety than white race. It was found that female sex was associated with worse physical function compared to males. And then it was also found that a greater proportion of Black and female patients lived in a more disadvantaged community. So this is one of the first graphs here. So this kind of shows the effect size as far as the different socio-demographics that we looked at, so race, sex, social disadvantage, and then compared that to the promise domains. And so here on the y-axis, we have kind of the like effect sizes, and then you can tell that the orange bar is social disadvantage, and so that had the greatest effect as far as all of the promise domains were concerned. So physical function, pain, anxiety, depression. Social disadvantage was affected the most compared to all of those. So physical function was around like 2.4 points, I believe, and then pain interference was around 3.3 points. Anxiety was about 4 points, and depression was 3.7 points. And then all of these results were statistically significant. This is another graph here that's kind of showing the association between socio-demographic status and then its effect on self-reported health. And so here kind of on the bottom corner, we can see that identifying as Black was associated with more of a meaningful associated risk with greater anxiety compared to white race. And then on the top graph, we can see that female sex was associated with worsened physical function compared to male sex, and that's here, the result here with the p less than 0.001, and that was statistically significant, and that was negative 2.5 points, which falls in line with kind of the point scores that I had like mentioned before. And then as far as the higher rate of anxiety in Blacks compared to another race, that was also statistically significant. The point value here was 0.003, and that was 3.2, which is statistically significant as well for this value. And then last graph I have here is the relationship between demographics and disadvantage status. And so each of these Q values here stands for like a decile, or correlates to the area deprivation index. And so Q1 would mean more of the less disadvantaged area as far as where you live, and then Q4 would be represent living in a more disadvantaged area with a higher ADI. And so as you can see here, the participants that identified as Black and those that identified as female resided more in the more disadvantaged areas, and those with a higher ADI value. Okay, so just a couple like things drawn from this study. So I would say some of the strengths include the larger sample size, which I think could also make the results a little bit more generalizable. As far as given that the institution is one that sees like a pretty diverse patient population and there's a lot of participation in the sample. However, I would say it was limited to a single institution and department. And so I think that also kind of limits the results. Other things I didn't kind of mention here was, as you noticed, as far as like the categories for race, it was only Black, white, and other. And so there wasn't much expansion as far as that. As well as like gender, it was just kind of male and female. And so there were, I guess, like limited categories as far as the demographic data. A few interpretations and conclusions from the study. So we saw that social disadvantage was one of the variables that correlated consistently with like worsened physical health and behavioral health in all of the domains, as seen on that first graph I kind of showed. And then kind of in relation to the hypothesis, identifying as Black was associated with only worse anxiety. So contrary to the hypothesis that it would be consistently lower amongst all of the categories. And then female sex was associated with worsened physical function. And so this kind of supports previous work that's been done regarding sociodemographic variables, like those of this study and those that kind of continue to strongly influence our health and outcome measures, and just kind of represent important things to continue to take into consideration. It also builds on the previous work that's been done, highlighting that our environment does have an effect on our behavioral and physical health for patients who are presenting with sports injuries. So always an important thing to take into account. And a little bit more discussion. So this study, I would say, did well in examining the role that race and sex does play in outcome measure results. And so I would say that the goal of this study was accomplished. I think that this study could have involved multiple hospitals to maybe ensure more of a representative sample. I think it would also be good to maybe take into account specific injuries or specific sports injuries. So maybe if they are doing this study in people who've only had like ACL tears, or people who've only had like a meniscal tear or something like that, maybe they could look at the results in a specific targeted group that is having pain. I think it also highlights the need to kind of target patients who are living in more of these disadvantaged areas and find better ways for us to ensure that they are receiving the care that they need when it comes to their recovery, because we know that we can't change more biological things like our sex or our race, but there are multiple social factors and multiple things that take into account how well patients are going to score on these outcome measures, and ultimately these things that influence the area deprivation index, some of them are preventable, and some of them we as future physiatrists or can help kind of modify or kind of manage and assess in our clinics. Black patients are also historically less likely to receive behavioral health resources or even be screened for things like anxiety or depression. And so it's just important to kind of take into account like the work that should be done when we explore what factors are impacting their scores, and better assess kind of how moving forward as providers we can target our practices when working with these patients, and when just kind of overall working towards their recovery and making sure that they're doing well, and how we can better influence their scores overall. So these are my references, and I thank you all so much for listening.
Thank you so much, Josephine. That was wonderful. Anyone have any questions? Dr. Fausett, any comments?
I'll open it up for questions first before I start in on it, if there are any.
Thank you for sharing. I thought that was a really great presentation. I wanted to ask a little on the functional recovery thing that you used, the PROMIS tool. Because I think that something I've learned, and I'm not even a physiatrist, is function is really hard to quantify. And it's really hard to like, so I'm kind of interested in, like, I know you told us a little bit, but like what other tools of function are you familiar with, and what do you think that one is the most like effective tool that we can use or something? Just I want to hear your thoughts on that.
Yeah, so as far as like patient outcome measures and like tools to measure like physical like function and recovery, I would say PROMIS is the, well, as far as I'm familiar with, it's the more popular one, but I guess it also depends on like what condition or like area that you're working with, because I know that like for spinal conditions there's like SRS, and there's like different things and like different sets of questions that you would go through. But I've heard good things about PROMIS as far as like the way it assesses outcomes and the questions that it asks, but I don't know if Dr. Fausett, you have any better outcome measures that you've looked into or are familiar with. I'm not super familiar with all of them, but I've heard.
I'm by no means super familiar with all of them either, because there are literally hundreds. I think for this study, PROMIS was probably the perfect one to pick because of what they were trying to measure, and the different factors for pain and how they can and how meaningful those factors like anxiety, depression, etc. are. There are a million different outcome measures, and you're absolutely right, Karam. Outcome and function are notoriously difficult to measure. You know, you'll hear a lot about FIM scores, FIM, when you go into physiatry. That was like the gold standard for a long time. Insurance companies still use it. They're absolutely awful. They're very subjective. They really do not do a good job of painting the picture. There are specific like body part ones, like for knees, etc. There's one called the WOMAC that gets used for the knee a lot. But in terms of like encompassing like whole person, mind, body, spirit, PROMIS is probably the best one that at least I'm familiar with. But great question. Other questions before because I've got a couple of thoughts on this wonderful study. Good, more time for me. Josephine, very well done. This is a complicated study, and their stats are very complicated. And they've got some the PROMIS is complicated. That whole quartile about the neighborhoods is very complicated. But I'll start at the beginning. I thought this study was very, very powerful and very, very well done. Dr. Chang, who's the first author on this, and Dr. Prather, who's the last author on this, they are huge names in the field of non-op musculoskeletal medicine, PM&R sports medicine specifically. Dr. Prather was the sports fellowship director at Washington University in St. Louis for many, many years. I think she's now retired and basically just does research. Dr. Chang is probably one of the top researchers in our field. She's just the best. So this study, I think, is really, really powerful. And it's trying to answer and discuss a very, very complicated question, as Josephine, you have figured out by trying to decipher this thing, because they go really deep with the stats and everything. So it's complicated, but I think it's really important for us to discuss. How and why people hurt is a huge, complex topic, and trying to put that into numbers is very, very challenging, but I thought they did a great job with this. Just some basic strengths of the study that I thought were remarkable. A 4-year follow-up, a minimum of 4 years of follow-up, is like really outstanding. I mean, you're lucky to get 6 to 12, maybe 18 months in a lot of studies. So the fact that they followed these people for at least 4 years is pretty amazing, and I just think strengthens their data. And then this is our population as future physiatrists and future sports medicine folks. You know, this is a non-operative population. And they took all diagnoses. You know, these were not people who were going to be eligible for a surgery that was going to fix their knee pain or their shoulder pain. So this is truly some of the tougher diagnoses and tougher populations in order to help alleviate their pain and everything. So I also thought that they did a great job, and Josephine, you did a great job by talking about using the minimally clinical difference, and they clearly stated that, and then they held to those numbers in their results and discussion session. There are studies out there that won't mention the MCID, and then it kind of comes out in the wash, and it's like, did they meet it or not? But they were very clear with that. So and I really like what you said about, like, you know, other things to, like, why are people in more socially disadvantaged situations, why are they worse off? And I would have loved if they could have looked at things like, how many PT appointments did they get? And how did that compare across the different quartiles? You know, what was their reported ability to exercise, and what was the reasons behind that? Did they not feel safe going out in their neighborhoods? Like, was that not an option for them because it was dangerous? Or perhaps they were working a very physically demanding low-wage job that didn't allow them time to exercise, or when they got home, they were just too tired to do an extra 20 minutes of PT. So I bet you they have that data, and I wonder if they're going to do future studies. I'd be fascinated about it, but I think those would just be some things that they would also, I would just be very interested in reading. So hugely complicated article, complicated topic, so important, and thank you for explaining it. That was really well done.
Thank you for those comments. Yeah, I'd also be curious to see if they continue to expand on this and look at the same, like, St. Louis area, and see if there's, like, specific factors that kind of influence this with those patients.
Yeah, and you know, they've obviously got more patients than you know, they've got a great N here. What was it, 1,900 people or something like that? I mean, 1,100 patients, all of 1,200. But yeah, I'm sure they could open this up and do promise measures from multiple other sites, as you were saying, like even within the state of Missouri or other places. There was one other thing that I was going to mention. Oh yeah, because this data for, like, which neighborhoods, like where they fall on the quartile, like, I'm sure that's available nationwide. You just type in the zip code, so like that data is already out there. So yeah, so I hope I'm sure that they will continue work along these lines. And I'm sure that they will come out with things like subgroups based on diagnosis, and start to explore some of those factors like PT availability, availability of local, fitness and exercise facilities, etc. So, yeah. I feel like I've been talking too much. Anybody else with questions or thoughts about any of that?
Yeah, this is Stacy. I had an awesome presentation, by the way, Josephine. It just made me think a lot, like as a provider, about like all the things that I'm wondering that we do different. We don't know it, and so I was wondering if, like I have heard studies before about like differences in like opioid prescriptions in the ED, for example, that are based on like race or other socioeconomic, like demographic factors. But in this study, did they touch on any like differences in what type of care these patients were provided? Like, I'm wondering even like amount of time the doctor spent with them, or like even like prescriptions given for pain management or referrals, like who received referral and who didn't. Like, was there any mention of actual like provider factors like that?
That's a great comment. I don't remember reading about any specific comments as far as things like that. I know they did take into account, so everyone saw, I think there were 8 different like non-operative physiatrists that were in the hospital. Other things that they did look at were like health insurance of each patient, and I know that the most common was, I think, private insurance, followed by Medicaid. But yeah, I'd be curious to know about, like how much time was spent with the provider and other things like that. But I don't remember specifically. But that's a great question.
I wanted to ask another quick question.
Mhm.
When you look at kind of like urban KC and urban St. Louis, and I'm sure we both know they're some of the most redlined regions in the entire country. And there's a lot of like differences if you go zip code to zip code. And we were continuously taught in med school that zip code is like the biggest predictor of health. And kind of going off of that, I was interested, like, as a future physiatrist or any kind of provider, and if you find yourself working with these populations, like, what are some possible interventions that they may have alluded to, or that you think that might be helpful, like whether it be like, I don't know, like screening for depression and anxiety, or I don't know, like working with the public health department for some like community level intervention, or something, or like maybe working on education, anything. Your thoughts on that?
Yeah, so that's a great question. That's a great comment that you make also. And so I think something that specifically I've always been interested in is also looking at like the social determinants of health. And so I know that within my hospital, my local hospital here in Kansas City, doing like the social determinants of health screening is becoming like a more common, and even like I think our hospital is considering like mandating the screening as well. And so those factors will also assess like, kind of like where you live, like can you afford your prescriptions, like employment, food, things like that. And so I think when we kind of shift more towards also looking at the social aspects of things through screening and things like that, I think that's where we get the kind of our greatest like awareness that this is an issue first. And then from there, I think it also comes, actually taking action to, work on those things. And so maybe having like social workers active and present within our clinics, or within nearby our physiatry clinics or areas like that, so that whenever patients do present with like issues or things like that, they can kind of be addressed, or we can be able to kind of adequately get them more resources. And then kind of like you mentioned, I think community-based like intervention programs are a good like next step as well. So
it's an incredibly challenging question, but yeah, I agree with everything that you've said. I just on a personal level, being kind of fresh out of training and everything, I think the thing that I'm trying to do as consistently as I possibly can is just when I explain the plan to the patient and when I develop the plan with them and, when I make recommendations about what I think would be best for them, I'm trying to, every single time, ask them, is this something that you feel like you're going to be able to do? And try to identify those barriers to care on an individual level. And sometimes I'm surprised by, all of a sudden I find out things that I didn't get in the history, like, oh, they have 2 jobs and transportation's tough, and like all this stuff that like did not come up in the discussion about their frozen shoulder. And then I realized that like what I'm thinking about for them in terms of their treatment is perhaps not a feasible thing. And so that's talking about on the individual level, talking about on a more macro level about how to address this at the neighborhood level, the city level. That's it just gets more and more complicated, doesn't it? So, but you got to be aware of it, I guess, is the point I'm trying to make.
Mhm.
And sub question, does it, Stacy and Roxy, does it vary from Santa Clara Valley to Stanford? I've never thought about that, but that's very interesting.
That's a good question. I'm not actually, and I think the problem with PM&R because it's so diverse, like it's you really need like an outcome measure in the different for the different settings. So like in inpatient rehab, we have one set, but outpatient would be completely different.
Yeah.
And I don't think we actually really have a lot of outcome measures, at least that I can think of, that we use for the outpatient setting. The pain clinic uses FIM scores a lot, but we don't. And yeah, I think the issue with it too, right, is also if you're not collecting the data, then you can't identify any issues in how you're delivering care, and you can't see how to improve care. So I do think that's to our detriment. Like, we don't really keep, we don't really take a lot of we don't take any Medi-Cal patients. But it's still unclear. Like, we don't really collect that data. Like, I feel like when I ask people how many Medi-Cal patients we are, or do we actually take it, everyone gives me like a different answer. So I guess just another push for just research just in general is it, you can't know that there's an issue if you don't look into it.
Yeah.
I totally Roxy. Just real quick. I feel like the only time I've ever seen outcome scores are either if insurance requires it, like a FIM score, and then I think the Valley is moving away from FIM scores. They use something else that I don't remember what it's called. And then the WOMAC, the only time I've ever seen that used was just for an attending who's leading a research project on like the efficacy of certain knee injections and doing like a pre and post. But yeah, I totally agree with Roxy that like I feel like if we need to more intentionally look at the data, more intentionally collect the data so that we have the data so that we can think about it.
Yeah, it's classically insurance driven, so money driven or research driven. And since I work at Kaiser Permanente now, so like it's very interesting that like the hospital and the health plan are all under one roof. It's complicated. I'm not sure I understand it, but basically what that means is I'm not worried about people's insurance because everyone has the same insurance, and I don't do any research in my current job, so I do not use any outcome measures in my day-to-day job. And I'm not sure if our physical therapists, occupational therapists on the outpatient MSK side of things are using any specific outcome measures. I bet you that they are, but I just in thinking about reading PT notes, nothing leaps to mind. So yeah, huge areas for potential improvement.
Anybody else? Anything else? Last minute to add? If not, we shall conclude this Journal Club. Thank you so much to both our speakers. Wonderful presentations. And also Dr. Fausett, your comments really helped. Like, I'm sure the speakers appreciate that as well. Thank you so much for your time and your expertise on this field. So Thank you everyone for joining us. Again, this will be posted on YouTube. And if you are interested in also presenting at a journal club, please reach out to us. But thank you so much for coming, and I hope you have a wonderful evening.
I just want to say thank you again. Great job to both of our presenters. Those were both excellent presentations. I so appreciate you guys having me be part of the session, and I really appreciate people staying up a little bit later and working around my work schedule. I know people are in the Midwest and East Coast, so maybe a little bit of a later night. So thank you guys so much. I really appreciate being part of the session tonight. Thank you.
Thanks so much,
Thank
and
you.
enjoy the rest of your year. It was so awesome to see you. I'm super excited for your journey and you attending. And seriously, thank you. This was lovely.
My
Thank you,
pleasure.
everyone.
Please have me back. Thanks so much, guys. Have a good night.
Thank you,
Thank
Dr.
you.
Thank you.
Bye. Have a good night.
Thanks, guys.
Thank you for
Bye.
moderating.
Oh, my pleasure. Thanks,
Thank
everybody.
you.
Great job.
Bye.